Everything we talked about, we're going to talk about again from the slide.
Professor.
Okay, so this is the set of slide that you have, one of them, okay? So again, this is again showing you what we just talked about yesterday. Is nicer here, of course.
What week is this PowerPoint under? I like to follow along in the.
Say it again.
Where is this PowerPoint?
It's in there.
All right.
You wrote text on materials.
Thank you.
Text on materials.
Thank you.
Go ahead.
Is this within system or pathology?
The name of it is called respiratory system. Pull it out. It's called respiratory pathology.
It's at the very bottom.
You got it? Everybody? Yeah? Okay, good. Okay, so basically this is what we talked about yesterday. It's a nicer one though, okay? So again, remember, you're breathing in and out. You see where I'm pointing? So inhalation, exhalation, inhale and exhale. That's going to be your tidal volume. That's going to be your tidal volume. Breathing in, breathing out. This is this part of the green line, green line. Okay. You're breathing in, breathing out. Then all of a sudden you take a deep breath in. Okay. That's going to be your. So it's going to be your the part that you take out. They don't have it here, but that's going to be your inspiratory reserve volume. Okay. What they have here for you. That's why yesterday I said what we want to concentrate on is going to be the forced vital capacity. Okay? The forced vital capacity, if you look here carefully, you can see easily it encompasses what? The tidal volume plus inspiratory reserve volume plus expiratory reserve volume. Okay? That's going to be your forced vital capacity. Forced vital capacity. Okay? So remember this, very important. Forced vital capacity. Forced vital capacity. If you want the numbers, how you get there, so the forced vital capacity is going to equal tidal volume plus inspiratory reserve volume plus expiratory reserve volume. Okay? Expiratory reserve volume. Okay? That's going to give you your forced vital capacity. Forced vital capacity. Okay? Now, why do we care about the forced vital capacity? Again, because we want to differentiate between obstructive lung diseases versus restrictive lung diseases. And the way we measure it in 1 second. And that's why you're going to see what is known as FEV, forced expiratory volume. So forced expiratory volume in 1 second. That's another one. The forced expiratory volume, FEV in 1 second. So basically, we're going to compare these two. The percentage of the amount of air you're going to breathe out in 1 second to the amount of air you took in. Make sense? And that percentage should be at least 80%. So 80% or more. So 80% equal 80% or more. One more time. The amount of air you're going to breathe in, that's going to be your vital capacity. Usually we refer to it as the forced vital capacity. Basically the amount of air you can absolutely inhale and put in your lungs. Okay? It's called vital capacity, but we're referring to it as the forced vital capacity because it includes stuff that you're going to force in. You're going to force inspiratory reserve volume and expiratory reserve volume. Those are forced. Make sense? And that's why we're referring to it as forced vital capacity. We're going to take that forced vital capacity and ask the patient. So basically what you're going to do, you tell the patient, breathe as much as you can. And they're going to take a deep breath. And then you tell them, you give them the instruction before they start doing it, of course, right? And then you tell them, when you get to the top of your breathing, I want you to exhale as much as you can. And then you're going to exhale, right? But you're going to measure the amount of air they will exhale in the first second. Okay? And that's what this graph is showing you. It's not showing you, if you look at the green, see the green part here, they have it highlighted, they're not measuring the amount of air you're going to exhale. They stop right there at the 1 second. And they're going to compare how much you are able to exhale out in 1 second from the amount of air you took in. Make sense? So it has to be at least equal to 80%. So you should be able, in the normal lung, so if the lungs are functioning fine, you don't have something obstructing you from breathing out, you should be able to exhale out 80% of the air you took in the first second. One more time. In a normal physiology, somebody who has no obstruction, that person should be able to exhale out 80% of the air he or she took in the first second. One more time. In a normal functioning lungs, when you don't have obstruction, see where I'm guiding you, taking you towards obstructive lung disease. Because these are the people who can breathe in fine, but they can't exhale. Make sense? When it comes to spitting out the air, they having difficulty. And that's why we're labeling them as obstructive lung diseases. So obstructive lung diseases, those are a set of diseases in which the person has no trouble breathing in, but they have trouble breathing out. It's called obstructive lung diseases. And we're going to go over the group of these because they are not able. So if you take the measurement and you find out that they were able to exhale out in the first second, let's say 55% of the air, that's not good. 65 is not good, right? Some people say 70 is fine, but right now I don't like 70. Most of the new books, the new instructions, they are going to go with 80. We want you to be able to exhale 80% of the air. Okay? If you are not able to do that, so there is something compromising the ability of spitting the air out or getting the air out of the lungs. Make sense? Everybody's good? Okay. But these are from all these nonsenses, I want you to just remember two, the vital capacity and the forced expiratory volume, okay? So these are the ones that we're going to talk about, okay? All right? Oh, okay. So this is basically another way of doing it. So this is the tidal volume, right? And this is the inspiratory reserve volume, all the way down from here, that's expiratory reserve volume, right? So this is another way of doing it. So again, these are the same numbers, IRV, the TV, right? You have the vital capacity, remember your vital capacity is the tidal volume plus inspiratory reserve volume plus expiratory reserve volume, okay? And then of course you have some air is going to stay in the lungs, and that's going to be your residual volume, right? And all these together, that's your total lung capacity, okay? All right? Okay? So basically, this is just that you are not, usually if you are doing a lab, we would do calculation, only you to calculate, give you problems to solve, and come up with what is the total lung capacity given these values. So you have to do the calculation. But for here, I want you to understand what we're going on. So this is what we're talking about. The FEV1 to the FVC, the ratio between the two. So basically you take the amount of the air the person is able to exhale out forcefully, and you have to force him or her to breathe out fast, okay? And that's why we call forced. Compared to the amount of air they took in, that's the ratio, right? So I'm giving you some numbers here. So I'm just gonna go over the numbers with you. So assuming that the forced vital capacity is 7 liters. Now, and you have 1 liter remaining. You have to take what remains in the lungs out of it, right? Because this is, remember, minus, you're gonna get a 6. So this person here, our patient, this patient here, was able to breathe in the first second 5.2 liters, okay? So, and then you're gonna take the ratio, 5.2 liters divided by the 6 liters that you took in, and your percentage comes to 8666, right? You multiply by 100, you get 86.6. So it's more than 80%, right? So this is a normal person, okay? This is somebody who doesn't have any problem breathing out. There's no obstruction here, okay? All right? So anything less than 80, right?
Why did you, for the FVC, why did you use 7 minus 1?
Because you have a residual volume, the amount that remains. Yeah, so basically, because we need just the forced vital capacity. We need just this amount. Okay. So yeah, so now anything less than 80%, remember this, anything less than 80%, we're talking about obstructive lung disease. Anything less than 80% obstructive lung disease. Okay. So basically what's going to happen, like for example, this here giving you, this is an extreme example. So this person is not able, instead of going all the way down, is able only to breathe out that much. Okay? So it's going to be your, yeah. Now this is another thing that I didn't give you, is called the flow volume law. Let's go over this. The flow volume rule. So basically, what is the flow volume? You have 2 axes. You see the 2 axes? So in the x-axis, you have the volume, right? In the y-axis, you have the flow. Basically, it's the speed by which the air is going in, okay? So you start breathing, taking air in, inhaling, right? Taking air in, taking as much as you can, and of course then it's going to slow down. It's going to come to a 0 right there, okay? And now you are exhaling. So you exhaling, and then it's going to slow down, and you come down, now you exhale all the air, you come to a 0 again, okay? This is normal. This is the flow volume loops, which is very, in this case, what you're looking at is a normal, right? Now let's look at somebody who has obstruction, not able to breathe out. What is going to happen to you're going to have a delay on exhalation. and that person is going to delay. So basically what's going to happen, this is the same one, just going down, 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 all the way up, right? Now look, look at the blue now. So this person has no problem inhaling, see? Basically, it's very similar to the black. So inhaling air is not a problem, right? Now let's look at the exhalation. See what happened? When you try to exhale, this is what's happening. You have this concave shape instead of going straight. Because this person here has obstruction. He's not able to breathe. So basically, breathing out is being delayed. Okay? Go ahead.
Pause more in the beginning of that?
Say it again.
Is the pause, is there like a pause in the beginning of that? Or more
No, there is no pause. You ask the patient to breathe in and then breathe out.
No, I mean, so if they do have the instruction and the time to breathe out, there's like a significant delay.
There is a delay. Instead of breathing in, breathing out, then breathing out become prolonged. Yeah. So the first, the entire breathing out is taking them very long time to breathe out. But the one we measure usually in the first second to get the range.
Is this what they're measuring when you have like one of those like little puffer things that you like shoot?
Yeah, that's a spirometer, right? That's a spirometer. Exactly that's what they give you. They give you a spirometer, and then you breathe in the spirometer, and they take the measurements. Yeah. So again, I wish we had a physiology lab where we can do this, we can do the measurements and all that. But anyways, but there's a couple of videos to show you. If we have time, we can do that. Because there's lots of measurement. There's another device. It's called the Buffalo something meter, where they put you in a sealed chamber. You sit in there, and they measure because they measure the amount of air in the chamber and the amount of air you are breathing in and out. Okay, so they're becoming very sophisticated. But we can take a look. Okay, so basically, all I want you to understand here, you're going to have a delay in exhalation. So remember, a person who has obstructive lung disease, what happened? I just lost it. Oh, here you go. So somebody who has obstructive lung disease, they have difficulty breathing out. Obstructive lung diseases is a group of diseases, the very important characteristic of which the person has a problem breathing out. They don't have any issue breathing in, as you see in the graph, but their problem is breathing out. That's a group of diseases we'll talk about. It's called obstructive lung diseases. Obstructive lung diseases. Obstructive lung diseases is a group of diseases in which the person is able to breathe in. They have no issue breathing in, their problem is breathing out. So exhalation is going to be prolonged and delayed. Go ahead.
Why would they have problems breathing out but not in?
Exactly, yeah, that's exactly what we're going to talk about. So I'm going to give you a set of diseases for which the person is able to breathe in and not to breathe out. We're getting there. Oh yeah, very good, that's a good question. So now let's talk about somebody who has a restrictive lung disease. But before we go there, I want you to think about what happens if you are digging a hole. It's a crazy example. And every time you dig dirt from that hole, some of the dirt you just did or dug out is going to go in. You're going to have the amount of air that stays in the lung is going to be larger with every breath you take in. And that's exactly what happens to people with obstructive lung diseases. Their TLC, total lung capacity, is going to be high. Makes sense? Because every time they breathe in, they are expelling some of the air, but not all of it. So the remaining air in the lungs from time to time is going to increase. Their TLC, total lung capacity, is going to increase. But I'm taking you step by step. I understand This is,
So is that what would be happening?
yeah, of course, yeah. See, as we move on, I'm just adding layers of information as we go. Okay? Now, look at the red. Now, I want you to look at the red. What is happening with this person? Compared to the other ones, compared to the black, which is normal, or even to the blue, right? This person is able to breathe in fine and breathe out. See, when you look at the graph like this person has but the amount of air they are taking in is little, it's small, right? So that's going to be your restrictive. The red here is the restrictive lung disease. Now, restrictive lung disease is somebody who is not able to breathe in. They don't have any problem breathing out, but breathing in is difficult. That's called restrictive lung disease. So what we're getting, two types of pathologies. One is called obstructive lung diseases, in which the person has no problem breathing in. The problem is breathing out. Their exhalation is delayed, is prolonged. Okay? Restrictive lung diseases, these are people who suffer from breathing in to start with. Okay? They don't have any problem breathing out. Even because the amount of air they took in to start with is not that much anyway. So breathing out is not a problem. The problem is breathing in. And that's what your red graph is. Okay? All right? So now, this is what I talked about this. This is what I gave you here. Everything in this slide is what this is, what we talked about here. When you have a mismatch. So when you have a mismatch, so basically you either have a dead space, basically you have it's called dead space ventilation. Basically you are ventilating, but there's no blood coming, so there's air but no, yeah? Or people who suffer from asthma, because right now we're going to the diseases, asthma, or COPD, or somebody has pneumonia, because pneumonia will give you the fluid, right? So now also another alveolar hyperventilation, or you have fibrosis, or this is ILD, stands for idiopathic lung disease, or interstitial lung disease, right? Or if you have a shunt. But we will expand on these. We will expand on these pathologies in a second, right? All right? Now, this is the graph I did in the board, but I have it here for you again, drawn again. Basically, comparing what you have. If you have to have a match. Anytime you have a mismatch, that's not good, okay? So basically, either you have edema, or you have fibrosis, or you have hypertension, okay? These are the conditions, pulmonary hypertension, right? So I have it here for you just to have it instead of the drawing in the board, okay? All right, so these are the conditions: edema, emphysema, you have alveolus as well, you have emphysema, you have fibrosis, right? Or pulmonary hypertension, okay? Now this again, I took this from another set of slides, but it's the same. There's no difference, so I'm gonna just fly over it, okay? Now, the good news, what is the good news? If you have a patient and you send that patient for pulmonary assessment, what is going to stand for, right? What's going to happen, the technician, they will do all the measurement and they will send you a report, okay? So in clinical settings, so you will get a report after they do all the measurements with the patient, and they will just send you the reports. They give you all the amount of air in and out, and all the capacities, all the volumes, and so on. Okay? All right, and that's it. So now, right now, we're gonna go over the slides, right? Take a break first, and then we'll go over the slides, and we'll start with certain diseases, certain conditions. Okay. So before we take the break, let's take the attendance. We'll take a 10 minutes break and then we'll come back.
I may have left the restroom. I don't know. It's not here. That's the issue. Nope. use quickly, don't they?
I think it always works better.
All right.
There we go.
Take a break.
It is, yeah.
Chronic obstructive pulmonary. Yeah, we're gonna go over it. Chronic
She's really excited about it.
Oh, yeah. He's actually.
Oh my god. Welcome.
Chronic.
Good morning.
I don't know how you're waiting. Yeah, I'm better than you, considering you're gonna be fast. Right.
My mind is set in motion by will.
Whatever.
My mind is set in motion by will.
Yeah, you were texting within like 150.
No, I like bring the same outfit.
I got twins.
Mine's better.
Hey, Gabby. Hey, Gabby.
Four and there's red. What?
Have you ever tried to explore out of your mind?
You? No.
Really?
No.
I know that feels so special.
No, like, it's bad.
It's so
And I
necessary.
told her that I wish you. Dude, that girl's crazy.
Just like Stranger Things stare.
No. Super smell. Not smell. It's a silent smell. Have you ever seen the show Psych? Okay, the character there who had super smell.
I'm glad it's
What about you?
Because I'm just like, I don't know.
If I'm going over, super strength, I'm going over. Okay. See, if I was over, see, no, I found it was behind
Okay, so how do I do it? You just feel like, what? Like, what is it? Yeah. No, that's totally me. Sorry. That's horrible.
I'm just waiting to see it.
One day, can we all
Start building what?
What do you think?
The anatomy to the professor.
Oh, that would be a good one too.
I actually didn't hear you. That's why I'm asking. I'm not trying to be snotty. Oh.
Yeah. This is not. That's not time. That's a lot smaller. I know. It's for what?
So, would I bring it?
I saw that yesterday. I was like,
Would I bring the Tupperware?
wait, I actually just said bar had a book
Okay.
upstairs.
I didn't know.
pictured the
You just said
Amazon page
bring
and I was
Tupperware.
like,
and I'm like, I'm
what
not
the fuck is
gonna
that?
Yeah, bring Tupperware.
It reminds me, it reminds me of those tiny little, I know, for kids family cups that you've seen. I'm like, what is this, a little swallow? Yeah. Like,
Yes.
yeah, go and
There's no reason
this
to
is
do
for
that.
kids.
No, I
10
just
ounces.
found it.
I didn't read that. I just saw that picture and I was like, oh, that's like 20 ounces. It's like a normal size shot.
Yes, and
This
one
for
of my I don't
shot, apparently. Like,
because she's her PowerPoint's all kind of
yeah,
like
that's
farming,
funny.
where she's just detailing different diseases that it's actually legible and follow.
about this stuff right now.
I feel that his description of pneumonia is accurate, where it's kind of difficult to breathe in. Good morning, how are you?
I didn't bring the pepper.
That's close enough.
He hasn't made it yet.
I haven't made it yet. I have to actually go and get the eggplant.
Oh,
Yeah,
when are you gonna do that?
between classes.
Why?
Because you put in a request. I have everything but the eggplant.
You want fresh egg?
Yes, always.
Always. Fresh egg.
Peel on or off? Do you want it with or without the shell?
The skin on any fruit or vegetable is like
It's
really
good.
toxic.
It's good fiber. Yes, but it's also very fibrous. So,
Is your mom alive?
yes.
Where's your mom?
I was wondering where that was going.
Very fibrous. Yes,
I
very
usually I
fibrous.
try to like when I meet people like try to like work it out with them like, oh, how's your mom? And they'll be like, oh, my mom passed. And I'm like, no mom jokes for you.
That's hilarious. The reason I got into chiropractic in the first place was because mom fell out of a tree.
Because your mom what?
Fell out of a tree.
Fell out of I thought you said your mom fell out you were a tree. I was like, oh,
No, she fell out of a tree.
I'm sorry. I'm glad she's here.
She was trying to put up a giant ceiling fan.
Is she doing
And from the
better?
tree?
Yeah.
Why?
It was over the trampoline, you know, over Willy Wonka, that the fizzy lifting drinks. We would jump into the fan. That was our fizzy lifting drinks. We throw extravagant parties, or used to throw extravagant parties.
Used to.
Yes. Mom got tired of it after the Harry Potter one. The Harry Potter party.
What happened there?
It was just, yeah, it was a big blowout party. It was great. We had a
Did it
basilisk.
come up at all?
Yeah, it was a paper made of paper mache. The head was the pinata, and we would send it down on the zip line, and people would just whack it. So you set that down right there and wait for me to fill it up with good food.
I know, but like, do I carry it around?
You sure? Yeah, absolutely.
But
Or you could just set it right there.
and leave it there?
Yeah,
What about between class? Should I just put it back where it was?
you can leave it right there, or you can leave it right. The Victoria's taking my spot, so I can't speak to that. But
You don't want to try to get that spot for her today.
you know what?
She might hurt you.
Oh no, why?
She'll
Is she okay?
She'll
No, she's.
Oh, she's just
Yeah, it's that. I'm just like,
she's scratching it.
I have right.
She's angry.
The house was an extra. Like, but even then, all that card is
Hilarious.
like, because I'm makes her more important. Even my mom, she like has like some friends, but it's also like, yeah, everybody else.
There's at least two others. That guy who wears the white guy who wears the like stiff brim hats. He sits like right there in the front row in the back. He's Canadian. Gotcha. I have a weird musculature weakness. I don't know what it is. I don't.
The body's getting really sick.
It's probably fatigue and things like that, but it's a little bit more difficult than it was last time to pump that good iron.
Anytime you get, that's what like happens is you start making good progress, start making really good progress, or like sometimes roll and sickness, and it's like you have to take a week off, and then just like.
No, I'm itching to get back there. I'm curious to see if there's any difference. I'm still a good 20 pounds down or so. I need to see if I can keep that going. Although I had my cheat day last night and cookies. Kind of upset about that, but I'll live. I mean, I figure I got like 20 pounds to play with, so I'll be fine.
Yeah, that's like you.
Yeah.
Do you take creatine?
No, I do a lot of protein powder. No creatine. I figure creatine's more like a short burst of energy kind of thing.
So creatine will do a few things for you. It does like sometimes helps with recovery, but it also does keep water weight and it makes you look bigger. Because I know you said you want more functional than just to look.
Yes.
So like it will make you gain a few more pounds initially, but it also makes you look more big.
Yeah.
So if I stop taking it, I'd probably shrink like a water balloon. But it's definitely.
And here I am admiring your shoulders, and they're just fake.
They are. I got the fake gym muscles right now. Just like if I have to go do something, like no, call Cole instead.
I found out a new way to do shoulders. You take the dumbbells, put them in your arm, your elbow kick, just do that. It's a good way to train like inner elbow grooves. If that really goes to the side of it. Yeah, exactly. It's actually not bad depending on what weight you have. My 20 pounds, I have one like normal weight, and the other one has like texture in the middle. So it's kind of weird to put in there, but still.
All right.
I have 235s and 220s.
In an effort to give you the total amount of money you paid for your time, we're going to start. All right, so the first few slides, it just give you like overview. Trust me, most of the stuff you're going to see in the slide, the stuff that I already went over, okay? But here we just not going to do it in a systematic way, right? So we already talked about this. So when we talk about the respiratory tree, now the reason they call it a tree, because if you look at the bronchial division, it looks like an upside down tree. So if you flip it upside down, it will look like the shape of a tree, okay? So remember we talked about conducting zone and respiratory zone. Now conducting zone is the area where you are sending the air or the gases, but you don't have exchange. That's going to be your conducting zone. You also call it as a dead zone, and that includes the stuff that's highlighted here. So the nose, there's no air exchange in the nose. The larynx, the pharynx, there's no gas exchanges. The trachea and the bronchi, there's no gas exchanges in there. The only time you're going to have gas exchanges when you get to the alveoli, okay? And that's going to be known as the respiratory zone, where you have the respiratory bronchioles, the tiny bronchioles, and then alveolar duct and alveoli, okay? That's going to be, these basically the areas that are involved in the process of gas exchanges, and that's why we call it respiratory zone, okay? Now epithelium. The epithelium that's lining this system, you have to remember this, is going to be ciliated, pseudostratified columnar epithelia, meaning that it has a cilia in it. And we already talked about the function of the cilia. The cilia basically work as an escalator, moving the mucus all day long from the lower part of the tract all the way up to your throat. You swallow it and you don't notice it. The only time if the cilia is destroyed. And what destroys cilia? Smoking. Right? So smoking. That's going to be your main culprit, right? So composed of a single layer of ciliated pseudostratified columnar epithelia. So replaced by cuboidal. Remember we talked about this? Replaced by cuboidal cells at the beginning of the terminal bronchioles. After that replacement by cuboidal, eventually it's going to be replaced by a single layer of simple squamous. Simple squamous, yeah. So basically it's a process of change. And I have all this in the other set of the slides for you to read, and it's in the book as well. So So basically, you change from being a cartilage to being a smooth muscle, then being simple columnar, simple cuboidal, and then eventually you end up to simple squamous. And that's when you're going to do the exchange of the air. Okay? All right. So basically, this is just the histology. Now, ciliated pseudostratified cover epithelia, so have a hair-like projection. That's what the cilia is. Help eliminate larger particle and mucus and the dust and anything that comes in that way, it just move it. Also has lots of goblet cells. Goblet cells, these are the ones that are responsible for secretion of the mucus, right? Mucus for protection, basically. Right? Now, additional layers, every epithelium, from back to your histology, every single epithelium, characteristic of epithelia, it has to have a basement membrane. Basically, where the cells are sitting, that's called a basement membrane. I can draw it for you here. So, I don't know how much histology. Basically, it's going to be your basement membrane. Under the basement membrane, you have some of the members, lamina propria, right? And that's where the cells are going to be sitting on top of the basement membrane. Because epithelia is always apical, meaning that it has to have a surface, free surface. Okay? So that's how the epithelia is. Okay? Now, smooth muscle, and I talked about the smooth muscle. We're going to touch on the smooth muscle again. We'll talk about asthma. Excuse me. Bronchial asthma is basically as a result of the smooth muscle that you have on the terminal bronchioles. And when they get irritated, they have inflammation, they're going to constrict, and that's what causes bronchial asthma. Okay? All right?
So for
Go ahead.
the basement layer or basement membrane, is it where you have like the little X's, or it's the?
No, this is lamina propria. This is the basement membrane.
Okay, so like the line.
The line, yeah. Where the cells are sitting. Imagine this like if you want to build like a brick house or something. So basically, you're going to have an area where you're going to have everything like, stacked. That's the basement membrane. The foundation, yeah, very good. That's a good one. All right. Now, obstructive lung disease. Here, answering your question. Obstructive lung diseases is a set of diseases in which there is obstruction of the flow of the air out of the lungs, right? So characterized by obstruction causing air to be trapped in the lungs. And this is the term we're going to use. It's called air trapping, right? So when you trap the air in, that means it's not being allowed to leave the lungs, and that's what's going to lead to increase of your TLC. Total lung capacity is going to be increased, okay? Narrowed or obstructed airways is slow exhalation, leaving an abnormal large volume of the air in the lungs after full exhalation, okay? How you diagnose it? You diagnose it by pulmonary function test, okay? Like spirometry. And this is the word that I can't for my entire life pronounce it correctly. It's called plethysmography. So basically, this is the one that you have the chamber, right? So the spirometry is easy because all you have to do is a device, you give it to the patient, and they have to breathe out, and you have the measurement of how they are able to breathe out. But these are the two ways you can diagnose pulmonary function test. These are the spirometry, which is like widely used, and plethysmography. Okay? Now, pulmonary function test, finding in obstruction, this is important. You will get tons of questions on this. So basically, what are the findings that you're going to see if this patient has pulmonary obstruction, right? Or obstructive lung diseases. And then listen here. What is going to happen? Your residual volume is going to increase. Why? Because you are not able to breathe to the outside. Residual volume and functional residual capacity is going to increase. Okay? Because your RV, residual volume, is the amount of air remaining in the lungs after forceful exhalation. Okay? So now your functional residual capacity, air remaining at the end of the normal exhalation. So these two values are going to be increased, and this is understandable because you are not able to exhale all the air that you just took in, right? Reduction in the forced vital capacity. So your FVC is going to be reduced. Not only that, the FVC is going to be increased, but the FEV1 is going to be also decreased. Okay? So these two are going to be decreased. So the total air expelled after a deep breath is going to be slightly reduced, and the amount of the air that you breathe out in 1 second is going to be decreased. Okay? And then we're going to measure the ratio, number 3. Okay? So number 3 is very important. So you will get in your questions, you will see that, well, somebody has the FEV1 ratio to the FVC is less than 80%. So if your ratio is less than 80%, that's diagnostic. That's it. You're done. That's that. You're going to label this person with obstructive lung disease. And then you have to go figure out which one. Because obstructive lung disease, as we're going to see, is a set of diseases. It's not only one disease. It's at least the one that are highly documented are 3 of them. And I'm going to give them to you in a second. Okay? So just remember, number 3 is very important. That's a hallmark of the diagnosis of obstructive lung disease. The ratio between the forced expiratory volume in 1 second and the forced vital capacity, less than 80%. Okay? Less than 80%. If you see somewhere it says less than 70%, that's fine. Those are the numbers, but the numbers keep, because as we progress in healthcare, we're trying to make these measurements slightly higher because we need healthy population. That's the whole idea here. The total lung capacity, remember the TLC is going to be either normal or in most cases going to be increased. Okay? Now, in restrictive lung diseases, the TLC is almost always going to be decreased because these are the people who are not able to breathe in. They are not able to take the air in. Okay? Emphysema cause air trapping in the lungs and hyperinflation. Okay? So somebody with emphysema, because they have destruction of the lung tissue, the septum is gone, so their chest is going to be very expanded to the anterior, right? We call it barrel shape, okay? So the chest will be like, the diaphragm will be flattened, right? I'm going to give you in a second. Why? Because there are tremendous amount of destruction to the lung tissue. The septum is gone, right? Now, VQ mismatch. Didn't we talk about this? And that's why I did it in the board first to get your attention and all that. But I have it here in very nice setup. VQ mismatch, ventilation perfusion mismatch, right? So V is the ventilation, the air intake, and the Q is going to be your perfusion. You cannot have an efficient air exchange if you are lacking one. You have to have both. You have to have oxygen, you have to have blood. Okay? If you are missing one or the other, you won't be able, there will be a mismatch. You have air, but there's no blood. Or you have blood, but there's no air. That's what the mismatch is. Okay? So it occurs when normal blood flow is present, but airway obstruct oxygen intake. Diagnosis using the pulmonary ventilation perfusion scan, or is basically going to lead to hypoxemia. Okay, so remember, what is hypoxemia? This is the term that mostly confused with another term which sounds like very similar. Remember, hypoxemia, emia means is blood, emia is blood, right? Reduced amount of oxygen in the blood. What is the other term? Hypoxia. What is hypoxia? The tissue. When the tissues are starving for oxygen, right? For example, if I'm going to raise my hand, I'm going to draw my blood all the way down or have a tourniquet here. Very soon you're going to see I'm going to have a lack of blood, okay? There's nothing wrong with my oxygenation. My oxygen is fine. However, now because I did this, now the tissues are starving for oxygen. That's hypoxia. Hypoxia, tissues are starving for oxygen. Hypoxemia, you have a reduction of oxygen capacity. the amount of oxygen in the blood is reduced. Make sense? Don't confuse the two. You're gonna see them. Some people confusing them, okay? Now, ventilation perfusion ratio or hypoxic vasoconstriction. That's the term for it. Remember I told you, in a normal physiologic condition, what is happening is if the blood comes to a certain areas in the lungs and they find that, oh, you don't have that much oxygen, what I'm gonna do, I'm gonna vasoconstrict. I'm gonna go to another part of the lung where I'm gonna enjoy tremendous amount of oxygen. That's physiology. This is called hypoxic vasoconstriction. Hypoxic vasoconstriction. Hypoxic vasoconstriction is when the blood vessels or the capillary in the lungs are going to vasoconstrict to divert the blood to areas where you have an abundant amount of oxygen. However, if it is happening on a larger scale, if everywhere you go, there is no oxygen, right? That's going to cause a massive vasoconstriction, and that's going to create resistance, right? That resistance is going to lead to an entire system being faced with tremendous amount of resistance, sending the blood out of the right ventricle. Remember, the blood is coming from the right ventricle via the pulmonary trunk. If it's not going smoothly, if there is a backup of the or constriction in the lungs, that's going to create what is known as cor pulmonale. See the word here? So over time, pulmonary hypertension sustains a right heart leading, sustain the right, there's a word missing here, right heart what? Sustains the right, yeah. So basically, continuous is going to lead to cor pulmonale. So cor pulmonale, most of the time, we will pronounce it cor pulmonale because it's a Latin term. That's a E right there, cor pulmonale. So remember, cor pulmonale, basically, you are having hypertension in the venous side of the heart, okay? So the right side of the heart having hypertension, and that's going to lead to hypertrophy. And remember, we talked about this, when you have cor pulmonale, you will have, when you have resistance, you're going to have the jugular venous distension, right? So the peripheral edema, right? The hepatomegaly, we already talked about those, so you already should know those, okay? As a result of hypertension on the right side of the heart. We talked about them when we talked about the valves, right? So, but now we're talking about from another angle. Gas exchange and DLCO, I already gave you this. Basically, you use carbon monoxide to measure the amount of movement of the gases between the lung alveoli and the capillary, okay? Why do we use carbon monoxide? Did you think about it? What the heck? Why are we using a small amount? Because if you give the patient too much carbon monoxide, you're going to kill them, right? So you're going to give them a small amount. Because you can measure it. Because we don't have carbon monoxide in the norm. You can use carbon dioxide because it's going to confuse you which one you are measuring. So that's the only reason we're using carbon monoxide. Gas exchanges varies by disease and assist in using the carbon monoxide measurement capacity. It's called diffusing capacity of carbon monoxide, okay? Which is the DLCO for sure. Now, you have to remember it because in the questions you will get, when we do the diagnosis, we're going to use the DLCO, okay? Now, the fluid volume globe, basically the one we just talked about. So in obstructive lung disease, the residual volume is going to increase, the total lung capacity is going to be normal or increased, and the loop is going to shift to the left, as we already have seen it, because you have a delay, right? You have a prolonged exhalation, okay? All right, now that's it, we're done. Now we're talking about specific disease. When you talk about chronic obstructive lung disease, the term that we're using, COPD, chronic obstructive, it should be disease, not disease. Chronic obstructive, because there's more than one, right? So, COPD caused by chronic bronchitis, emphysema, often coexist together. So basically, most of the time, if somebody has bronchitis, they probably have emphysema. They come together. The thing is, like, which one they have more? They have more of bronchitis or more of an emphysema presentation, right? So chronic obstructive lung disease. So smoking is going to be your domain. So occupational pollutants sometimes, people who have is exposed like dust or silica, some environmental factors can cause it, but the main cause is smoking, right? So COPD. Now chronic bronchitis. Now, one thing you want to remember about chronic bronchitis, you have an inflammation, okay? So chronic bronchitis is inflammation. Chronic bronchitis is also a clinical diagnosis. What does that mean? So basically, we are relying on the clinical picture, okay? That's why we say it's a clinical diagnosis. Emphysema, on the other hand, it is not. You can't diagnose it clinically. You can have an idea that this person more than likely have emphysema, but to get to diagnosis, the best way of diagnosing somebody with emphysema is to take lung tissue, take it to the lab for histology. So it's a histologic diagnosis, right? But chronic bronchitis is not, okay? So inflammation, tracheobronchial tree, excess mucus production. Triggers is going to be smoking, pollutant, right? You're going to have hypertrophy and hyperplasia of the mucus gland. These are your goblet glands. So you're going to have too much of mucus. And that mucus, what it's doing is blocking the airways, okay? So now, the read index. The read index is so useless index. Why? Because you have to take it after death. So it's post-mortem diagnosis, okay? So, and that's what the coroners, medical examiners will use the read index. But you can't do it in a living person, right? It's a post-mortem test. So normal is less than 0.3, the thickness basically of the layer. With chronic bronchitis is more than that, okay? In some cases like double or triple the amount, okay? But we don't use it in clinical setting. And that's why the diagnosis we have it in here. So basically, somebody, they have a productive cough for more than 3 months for 2 years. So if you're observing a patient, right? If your patient tell you, oh, you know what, doctor, I have chronic cough. First, it's going for like 3 months. And you're observing this patient, been treating this patient for the last 3 months, and they still have mucus secretion, abundant amount of secretion. If it goes for 2 years, that's the criteria. This person is going to be diagnosed with chronic bronchitis. The label basically, right? So when you hear the lungs, you're going to hear wheezing, crackles, right? They will have hypoxemia, hypercapnia. What the heck is hypercapnia? High level of carbon dioxide in the blood, hypercapnia. Capnia is carbon dioxide, okay? Hypercapnia from mucus blocking the air exchange, right? And sometimes they will have what is known as a shunt of the blood. We call them the blue waters, okay? Blue waters because they look cyanotic, right? So they look cyanotic, okay? Increased pneumonia risk due to the mucus obstruction. Let me draw this for you. So basically what's going to happen is this. Now, you have alveolus, right? I'm going to give you a terminal duct. This is going to be my terminal duct. This is my alveolus, right? So areas in the lungs, remember this for the rest of your life. You're going to see in your clinical settings that anytime you have a blockage, for example, if I have a block here, right? Mucus block, areas that are not ventilating as a result, because it's closed, right? You're not getting air in, okay? So this area is not ventilating. Areas of the lungs that are not ventilating properly, you're going to develop infection. This is the same reason why after even, I don't know, the most serious surgery ever, you know somebody underwent a surgery, right? What are they going to do? If they can't move you, they're going to make you do what? Breathing exercise in bed. Otherwise, they want you to get up and start moving. And you sometimes patients wonder like, what the heck? I just had surgery yesterday. Why are you getting me to move? Because we want you to breathe. Because laying down is going to cause pneumonia. And the last thing a hospital wants is an intra-hospital infection. That's why they want to get you on your feet and start moving right away. If you are not, for whatever reason, you can't move, for example, you have hip surgery, you can't move right away, they will bring you something to breathe in. And that's you're going to get their respiratory therapists, they're going to get their nurses, they're going to make the lungs to work. You have to get the lungs to work. Because anytime the lungs are not ventilating properly, you're going to hit up with infection. Makes sense? And this is exactly what happens here. If you have a block of mucus preventing the air from having exchange of the air, is going to lead to infection. Go ahead.
So for productive cough, that's like when it's like that kind of croupy, crackly cough, right?
Yeah, absolutely. Copious amount, yeah, huge amount of mucus. Of course.
Not to give a demonstration, but
What is popcorn? I'm not sure. Popcorn. From vaping? I don't know. I'll look it up. Oh, breathing out? The sounds. Oh, the sound. Oh, that's a crackle, right? Yeah, yeah. So basically, and I have a presentation for you. We're going to do it Wednesday. So I'll have the sounds for you. Okay? You're going to do this when you do your visceral diagnosis with the stethoscope. They'll talk to you about the sounds again, but it's a crackle. Because when the mucus, when this sometimes open, when the mucus open, so the air going to move over it, it's going to make that sound. Okay? Crackling sound. Okay? Now emphysema. So chronic bronchitis, any questions? Chronic bronchitis. So basically, remember, chronic bronchitis is a clinical diagnosis based on the clinical picture. A patient that comes to the clinic and having productive cough for 3 months, for 2 consecutive years, that's a chronic bronchitis. Okay? Emphysema is totally different animal where you have a destruction of the septa, right? So the pathophysiology, permanent alveolar enlargement, loss. I can show you the histology. But usually, you don't get histology here. In my medical school students and nursing school, because we test them on the slide under the microscope. They have to diagnose the patient with just using the slide. But I can show you the slide just to show you what the structure will look like, okay? So permanent alveolar enlargement and loss of the elasticity. You lose the elasticity, okay? Now, the lungs, they secrete elastase. It's a protease, it's an enzyme secreted by neutrophils, and that's going to lead to destruction. So as part of the inflammation and the long-standing smoking, basically you have these chemicals, and these chemicals destroying the septa and leading to the alveolus being, instead of having nice alveoli like this one, the one that I have here, so you have one like this. Nearby you have another one. I'm going to do another one right here. Right? So basically this is what you have. This is what the histology is, right? Of alveoli like this, several of them. Okay? Basically what's going to happen, when you have them as one at a time, you have more surface area. When the septa between them is destroyed, basically I'm going to destroy the septa. Look at this. So basically you end up having like this, having something like this. This is opening here, and this opening here. All of a sudden, you have this huge alveolus like that, and you lose tremendous amount of the surface area. Okay? Now, don't worry too much about the types, but these are the types. The centrally acinar emphysema, this is the most common one, and then you have the pan-acinar emphysema and paraseptal emphysema. These are different types of emphysema, but in reality, what's happening is the destruction of the septa. Okay? Now, what they're going to have progressive dyspnea. Dyspnea is difficulty breathing, and these are the people that they learn. They have to breathe very slow. It's called first lip breathing, right? Basically, they breathe in. They try not to breathe fast because they learn that if they breathe faster, they will have a collapse in the lung. They suffer. So, like somebody puffing like something, very slow. They are called lips breathing. Yeah.
So when it destroys the septum, it essentially limits the amount of like surface area that it can.
Exactly. Yeah. You're limiting the surface area. All right. So whereas lip breathing, and they will have barrel shape because they have hyperinflation, right? And of course they have hypoxemia. Okay? So basically, the anteroposterior, the AP diameter of the chest will be forward, right? So basically somebody like a barrel, right? Called the barrel shape. Okay? COPD diagnosis. So pulmonary function test. This is everything here, everything we just talked about. So pulmonary function test is going to be you're going to have obstruction confirmed by if the FEV1 to the FVC. Let's see, I gave you 70% here. Why? Because I just took it from the book. Because your book, your textbook is saying 70%, right? But the newer books, newer instruction manuals are saying 80%, okay? Now, post-bronchodilator test. Now, why are we doing this? So basically, what you're trying to do, you have a patient, right? And you do the measurements, and it comes less than 70%, right? Then you give this patient a bronchodilator, albuterol, for example, right? And you tell them, okay, here, inhale this. And you measure again. If you have an improvement, if you have, these are the numbers. If you have an increase, right? So if more than 12%, basically, after you give them the bronchodilator, they have a very good breathing out. Then this patient is suffering from asthma, makes sense? Because asthma is another type of chronic obstructive lung diseases, makes sense? However, your task is to differentiate, is it emphysema or asthma, okay? So you give them a bronchodilator. If they dilate, oh, good news, because asthma is better than, it was bad, but asthma is better than emphysema. So now you have to treat this patient as an asthma, not as an emphysema, because the treatment is going to be different for both, okay? Chronic bronchitis is going to be based on the criteria I gave you, okay? So chronic bronchitis, diagnosis based on the productive cough, 3 months for 2 years, right? Now, emphysema diagnosis, I already told you. So basically, you do a CT scan of the lungs, X-ray. What you're going to see? You're going to see enlarged air spaces. You're going to see a flattened diaphragm and increased lung lucency. Basically, the lungs are going to be filled with air, right? So, but you will do this again when they will show you the X-rays when you get to the X-ray diagnosis. You have an entire class on that. Now, remember this: the DLCO. What is going to happen is going to be decreased in emphysema. It's going to be normal in chronic bronchitis. Now, alpha-1 antitrypsin screening test is good, but usually it's done for somebody young. Because if you are 7 years old, right? So more than likely you didn't start smoking yet, hopefully, yeah? So then there is something else destroying the alveoli. Now, in that case, some people suffer from certain diseases, so we have to screen them for what's known as alpha-1 antitrypsin. Alpha-1 antitrypsin, because certain diseases like fibrosis and all that, these people are both suffering from genetic malformation, and their body is secreting huge number of this enzyme. As a result, they're getting the destruction because we're excluding other pollutants, we're excluding smoking and all that. So it has to be something genetic. Okay? All right. Now treatment. Usually you have to reduce the risk reduction, smoke cessation, right? Infection control, like the flu vaccine and so on, right? Acute exacerbation management. If somebody has, for example, they are known to be with chronic bronchitis. Now all of a sudden they develop fever, right? Chills and other symptoms. And in this case, more than likely they have an infection, right? So they will have antibiotic, right? Corticosteroids, short-acting bronchodilator like albuterol and so on. Now, supplemental oxygen, the reason I say with caution, because sometimes, usually you have to give the oxygen saturation shouldn't exceed 90%, okay? Why? Because people, particularly people who suffer from emphysema, they rely on the receptors in the lungs to let them know when they develop hypoxemia. So if you give them oxygen supplement, that's going to saturate their blood with more than 90%, they lose the sensation that they are not feeling well, they don't have dyspnea, makes sense? And that's why you usually have to be careful with the amount of oxygen. But you don't have to worry about this because this usually in either emergency rooms or people who is prescribing oxygen for this patient, right? Now, long-term treatment usually is going to be your long-acting beta agonists, like the one that is formoterol. There are several of them. This is just an example. Long-acting muscarinic agents and oxygen. Usually the one that in advanced form of emphysema, these are the ones that they're going to be having oxygen at home. Okay? Asthma. Now, what is asthma? Now, asthma is inflammation. Okay? Something is triggering the inflammation. Usually, some sort of pollutant, right? So pollen, certain smells, certain odors, right? Something is causing it, right? So inflammation. So basically causing inflammation, hypersensitivity for certain chemicals, right? As a result, you're going to have bronchoconstriction. So these smooth muscles that we talked about are going to constrict. And as a result, they will have difficulty breathing out. You don't have any problem breathing in. Breathing out is a problem, okay? Now, triggers going to be your genetics, of course, environmental like pollution, smoking, allergens, and so on. Now, dust, dander, mold, there's a wide range of it. Sometimes a patient can figure out which one. In some cases, it's difficult to pinpoint, what's causing it, right? So, but if the reason we are trying to find out what is causing it, because if you avoid what's causing it, for example, particularly right now, it slowed down after the amount of rain we had, but like a few months, like a month or 2 months ago, you'll see these patients suffering a lot because you have tremendous amount of pollen, right? Particularly in Georgia, we have lots of trees, right? Now, another type is going to be the one that's known as aspirin induced. So some people, for whatever reason, it has something to do with the leukotriene overproduction. That's what part of the aspirin medication. Actually, in some cases, other non-inflammatory, anti-inflammatory drugs like ibuprofen and so on can cause it too. But the one that is known to cause it is aspirin, right? Now, so the triad of asthma, nasal polyp, this is known as a Jacqueline syndrome. I don't know why I have it here, but I don't think you're going to have any questions on this. Physiology, type 1 hypersensitivity, basically type 1. So it's an inflammatory process, right? Are you getting immunology now or no? Oh, when you get to immunology, they will talk to you about these, type 1, type 2 hypersensitivity reaction. Basically, it's an autoimmune reaction. So basically, your immune system is calling for a reaction. And that reaction, as a result, you are secreting lots of chemicals called cytokines combined, right? And as a result, it's listed here, interleukin 4, interleukin 5, 13, and so on, right? Basically, it's an immune reaction. As a result of these chemicals being secreted in abundance in the lungs, you have vasospasm, okay? Histamine, leukotriene, prostaglandin, and so on. But all of them are calling for bronchospasm, okay? Now, symptoms, basically, they will have episodic cough, wheezing, dyspnea. As a result of the dyspnea, you will have the tachypnea, right? So, sometimes the cold weather, it works as a trigger as well. Usually, in the winter, they suffer cold air, smoke, allergen, and so on. Okay? what they're gonna have prolonged expiration. Remember again, this is obstructive disease. So any obstructive disease we talked about so far, you have a prolonged or delayed expiration, right? So expiration ratio 1 to 4. In some severe cases, it can go all the way 1 to 5. Okay. Then you have pulsus productions. Basically, you have a difference in the pulse. So about 10 or greater than 10 milliliters of mercury drop in the systolic pressure during inspiration. That's what's known as pulsus productions. Because of the hypoxia, because they are suffering from not getting enough oxygen, right? Now, diagnosis, again, the same thing, no difference. It's an obstructive lung disease. All you have to do is spirometry. In the spirometry, you're going to do what? You're going to get the ratio, the FEV1, the FVC, and if it is less than 70%, that is going to be diagnostic. The problem with asthma, though, is when they come to the clinic and they don't have an attack, they are fine. It's tough to diagnose them because in some cases we have to call for it, right? I don't know if I can hear. Beta calling. So you give them a drug, a medication, to call for the asthmatic attack because you want to do the measurement. Okay. So basically, because a normal person, if you are not suffering from asthma, if I give you the injection of the methacholine challenge test, nothing is going to happen to you, right? So, but if your FEV1 is going to drop more than 20%, it's going to be positive. A normal person with no asthma, nothing is going to happen. They won't have any drop in the FEV1. Now, your DLCO is going to be either normal or increased. Speed of finding, don't worry about this part because this is usually for the slide, for the histology. You can do somebody, the Krishman spirals and the charcoal light and all that under the microscope. You have to diagnose it when you do the diagnosis. Treatment, bronchodilators. It's very simple. Now, asthma is called the step-up treatment. Usually, and this is something that we warn residents of doing, you have to start with the most benign, the low-level bronchodilator. Okay? Sometimes some physicians are very aggressive. They jump into the high. There's a first tier, second tier, third tier. You don't want to start from the second or the third. You always start with the lower one. Because sometimes if it's a mild asthma, some people just suffer from a mild asthma. They have the asthma during exercise or when they do like some work, exertion, right? Or sport, what's known as a sport triggered asthma. They go for a run or something, and then all of a sudden they have wheezes and all that. All you have to do is albuterol, a mild form of bronchodilator will do it, right? First line, okay?
So after like multiple years of using it, can it like create almost like a dependence on it?
Not dependence, create resistance.
Resistance. Okay.
Right, and that's why we move. That's sometimes somebody, not everybody, some people respond very well though. So if somebody develops resistance to one bronchodilator, and that's why we call it a step up. So you have to get a more potent one, right?
Okay.
But you have to do it very judicially. Yeah, so you basically have to think about what you are doing, not to jump because some of them are having combined bronchodilator and steroid together.
Yeah.
So you have to reserve those for later on. Yeah. Believe it or not, although sport induces asthma, but some people who suffer from asthma, when they exercise, regular exercise helps. Because during regular exercise, you are breathing very fast, right? And that training for a long time, it helps tremendously in decreasing the amount of episodes. All right? Now the last one we'll talk about here is going to be your bronchiectasis, then we're going to go over the main points. Bronchiectasis is the third one. So remember, all we're talking about now is chronic obstructive lung diseases. We started with chronic bronchitis, then we did emphysema, then we did asthma. The third and last is going to be your bronchiectasis. 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 Basically what's happening here, you have a chronic inflammation. Chronic inflammation that leading to dilation of the airways, mostly the terminal bronchioles, and you have tremendous amount of mucus production. This one is easy to diagnose because an X-ray would show. If you take a chest X-ray, it will show the person has bronchiectasis. Okay? So primary cellular dyskinesia, Cartagena syndrome, that's basically one of the causes of it. Now, it's people who suffer from cystic fibrosis, sticking mucus obstruction, and allergic bronchopulmonary aspergillosis, right? So this is going to be infection, basically. As a result, you have obstruction of the airways. They will come with wheezing, chronic cough, like usually their cough, when they're coughing, like bad smelling sputum, right? In some cases, they might have hemoptysis and clubbing of the digital part of the nails, digital clubbing. And they will suffer from recurrent, because they have tremendous amount of mucus built up that's going to cause blogging of the airways, causing infection. Okay? All right. Now, the main point, I have the main points here for you. So basically, the first one here, asthma, characteristic defined by chronic airway inflammation leading to variable airflow obstruction. Trigger of the asthma exacerbation can be triggered by physical activity or exercise, known as exercise-induced. High altitude. Why high altitude? Because you have low level of oxygen, right? So occupational exposure, right? COPD versus asthma. Just remember, COPD is characterized by progressive decline in the lung functions, unlike asthma, which is often reversible. Yeah. So you don't have a reversible when it comes to emphysema. However, in asthma, it's reversible. Okay? All right. Asthma management goal to maintain airflow, basically, normal lung function. Common feature of the asthma and COPD, they both condition involve airway obstruction, but COPD is less reversible. Okay? Primary cause of COPD, tobacco, smoke, right? And symptoms unknown in asthma. You don't have hemoptysis or coughing blood. It's not typically associated with asthma. That's bronchiectasis. Okay? Peak flow monitoring in asthma is used to assess medication effectiveness and monitor the disease progression. Okay? We're going to do this again, believe it or not. We'll do restrictive lung diseases on Wednesday, right? And I have a couple of presentations for you to watch where you have the sounds. Yeah. So as I said, we're going to repeat most of the stuff that we talked about is going to repeat several times. Okay. All right. Don't wait for me though. I have everything that you need for you. The slides are in there. Go over, finish the first set of the slides, and then do this one. Make sure you practice. All your quizzes are open. Practice, practice, practice. It's unlimited amount of practice you can do. All right? Any questions? I will see you Wednesday.